This program is sponsored by a grant from Medtronic. I want to introduce our moderator, Dr. Sunil Roy. We have two distinguished international guests, Professor Murasato from Japan, who did a lot of the bench work in OCT imaging and bifurcation PCI, particularly side branch wiring, who started recorded presentation. Junji Zhang from Nanjing, done a lot of work with DK crush and bifurcation stenting, particularly left main stenting. He was the principal investigator of the ultimate trial, utilizing intravascular imaging. Our panelist is Natalia Echeverry from Canada. Our chat moderator, John Lisco. And our case presenters are Richard Schlafmitz from New York and Junji Zhang from Nanjing. So without ado, I'll pass it on to Sunil. Please note this is a MOC program and you can get credits on ABIM as well. Thank you. Sunil, if you want to take over.
Great. Thanks so much, Tanvir. We've got a tremendous number of attendees online, so really excited to get this going. I think Professor Murasato has a presentation to start, which is OCT imaging and bifurcation stenting. So Professor Murasato, if you want to go ahead and play your talk.
Thank you for invitation.
Thank you for invitation to SCAI Bifurcation Club webinar. I'm Yoshinobu Murasato from Kyushu Medical Center in Japan. My topic is OCT in coronary bifurcation stenting. There is no conflict of interest. We respect the laws of imaging in bifurcation PCI as follows. In pre-procedure of optimal selection of devices and PCI strategy are important. First, measurement of dimension of lumen and vessel in member cell and side branch. Second, assessment of atherosclerotic plaque morphology, burden, longitudinal distribution, calcification, and negative remodeling. Third, detection of angiographically silent disease. Fourth, assessment of the risk of side branch compromise. In post-PCI, optimization of procedure is crucial for better clinical outcome. The following should be assessed in imaging. First, stent apposition. Second, stent expansion. Third, full lesion coverage by the stent. Fourth, stent edge dissection. Fifth, plaque prolapse inside stent. Sixth, side branch residual stenosis and dissection. Seventh, optimal guidewire recrossing before side branch dilation and subsequent adequate clearance of J-ring struts after side branch dilation. According to the bench testing, we believe this strut wiring can achieve the wider opening for the side branch. On the contrary, proximal wiring promotes protrusion of the distal strut into the member cell. However, guidewire recrossing in the farthest cell, which means 90% of the strut cell embedded in the distal side, causes significant stent deformation induced by side branch dilation. Here you can see side branch balloon straightening causes the expansion of the distal cell into the proximal side. This is the actual clinical case, guidewire recrossing into the farthest cell. As a result, final Kissen balloon inflation causes the stent deformation in the distal side, extension to the distal strut to the proximal side. On the contrary, guidewire recrossing in the proximal side, as you can see, 3D OCT demonstrated guidewire recrossing in the proximal cell clearly. However, on-site, we only perform the 2D OCT guidance. We cannot identify the guidewire recrossing point precisely, so we perform side branch dilation and subsequent report. As a result, adjacent cell was protruded into the member cell lumen, and a subsequent report induced turned back to the distal side to the protruded cell. In the 3D OCT bifurcation registry, 3D OCT guidance efficacy for the successful rate of the optimal guideway recrossing. Initial success rate by angio guidance is only 66%. It is elevated to the around 90% by accumulating 3D OCT guidance. And especially in the left main, initial success rate by angio guidance is only 56%. This is a comparison between the 2D and the 3D OCT guidance concerning the incomplete center position, especially in the left main bifurcation in cases. 3D OCT guidance significantly lower percentage of the incomplete center position compared to the 2D OCT guidance. Optimum study is a randomized control trial comparing the 3D OCT guidance and the angio guidance in the provisional bifurcation stenting. Online 3D OCT guidance significantly lower percentage of the incomplete center apposition compared to the angio guided arm. From the 3D OCT bifurcation registry, we also clarified the effect of the stent ring connection on remain J thread after Kissen balloon inflation. According to the existence of the ring connection at the carina side, we divided the two types, free carina type and the connecting to carina type. In the free carina type, the optimal wiring can achieve the wide side branch opening. On the contrary, ring connecting type, even after optimal wiring, the ring connection still remained after Kissen balloon inflation. We also analyzed the predictor of the incomplete center apposition on side branch ostium side. Ring connecting type and optimal distal recrossing are the strong predictor of the incomplete center apposition. This is the actual clinical case of the ring-free type. The upper case first attempt of the guideway recrossing failed to the optimal wiring, and the second attemptation we succeeded in the optimal wiring, and the final Kissen balloon inflation promotes the wide opening for the side branch. And the lower case, similarly, first attemptation was failed, and the second attemptation was succeeded in the optimal wiring, and wide opening for the side branch was obtained. This is a ring connecting type. The upper case guideway recrossing to the larger distal cell, it resulted in the sufficient expansion in the side branch ostium. On the contrary, in the lower case, guideway recrossing in the smaller distal cell. As a result, the final Kissen balloon inflation cannot achieve the optimal side branch dilation. Ring connection still remain in the center of the side branch ostium. Therefore, we add the new type for the gel instrument patterns. The link-free type and the link-connecting type and the no or less jailing type. In the link-free type, 3D OCT guided optimal side branch dilation was strongly recommended. In link-connecting type, aggressive part change to the link-free were no or less jailing type was recommended. And secondly, guideway recrossing to the larger distal cell is recommended. And no or less jailing type, we have a confidence to leave the side branch undilated. There are weak points of OCT observation in LMCA bifurcation. First, a difficulty in obtaining clear visualization in proximal LMCA, and frequent observation requires lots of contrast medium. In such case, which has a LM ostial region or big left main with some disease in the branch area, in this case, LAD ostial region. In this case, OCT observation is very difficult. In such case, we use the see-through technique using a guiding extension catheter, especially a telescopic telescope is very useful to see the proximal side using the backflow from the tip of the guide extension catheter. A telescope has a helical coil in this body, so infrared light can penetrate into space of the coil. This is the actual case. OCT pulled back from the LED to left main. Here you can see there is a calcified region, and the tip of the guide extension catheter can penetrate the infrared light. This is the body of the guide extension catheter. Telescope has a helical coil. Into the space of the coil, we can see the left main body. Another problem is the contrast medium. This is a case of a diffuse LED region. We treat the region with two drug electric stand. We compare the image quality between the contrast medium and low molecular weight dextran. Low molecular weight dextran is useful to clear visualization and remove the red blood cell from the observed vessel. Here you can see there is no significant difference between the contrast medium and the dextran. Our Japanese colleague, Dr. Kurogi, recently demonstrated the efficacy of dextran for OCT or OFDA guidance. Here you can see in terms of the amount of the contrast medium, they compare the OCT guidance and the IBAS guidance in propensity match analysis. There's no significant difference between the amount of the contrast medium between them. This is the case of the 72-year-old male with effort angina. Here you can see LED diagonal bifurcation region. We decided to treat this region with the two stent by a minimal culotte stenting. Firstly, we implanted the diagonal branch stenting with a 2.25 millimeter stent. And then LED wiring was performed. This is the 3D OCT images after rewiring to the LED. Here you can see a guide wire recrosses the most proximal side of the diagonal branch stand. So this is a one-string culotte stenting. After opening LED ostium, the LED stenting was a 3.0 millimeter stent was performed, and then a report was performed by a 3.5 millimeter balloon. Then rewiring to the diagonal branch was performed, and 3D OCT images of this, and the wiring to the middle cell. However, we considered farthest cell crossing with the link connecting type is not suitable for this region, so this recrossing points are optimal for this case. So we dilated with this the cell, and the Kiss-Barlow inflation performed, and the report was performed. And this is the final angiography. Both branches were beautifully dilated. This is my conclusion slide. OCT guidance in bifurcation PCI is useful in pre-PCI for accurate region assessment and optimal device selection in each branch. In the PCI optimization, it is also useful for checking the sufficient stent expansion. And in terms of optimal wiring, 3D OCT guidance elevates the success rate for the optimal distal wiring. And it is also useful to stratify the side branch dilation according to J-ring strut pattern on the side branch ostium and prevention of abnormal wiring. This would lead to less incomplete stent apposition, J-ring struts, and deformation. Thank you for your attention.
Thanks very much, Professor Murasato. That's a really very, very informative talk and really outstanding use of OCT in one of the more complex aspects of bifurcation stenting. I want to remind the attendees to please enter your questions in the chat so that we can field them as panelists. I think in the interest of time, maybe we'll move on to the second talk, which is bifurcation case presentation with OCT imaging and optimization with Richard Schlafmitz.
Thank you. Do you have the screen there?
We're seeing your Zoom screen, Richard. We're not seeing your slides.
Okay, let's see. Why share screen? There we go. Sorry.
There we go. Yep, we see it.
Okay, there we go. Sorry about that. All right, so I'm going to be talking about optimizing bifurcation treatment. And I'm going to show it with Boom with the Ultron 2.0 software. And this is the new Abbott software from what we've been using for several years. The Boom technique is also mini crush or nano crush, different names. I call it bifurcation OCT management. So basically, this was a 65-year-old male coming in with shortness of breath with a positive stress test with anterolateral ischemia. And on the angiogram, you could see that he has an LAD lesion with a diagonal bifurcation. And anytime I have any kind of bifurcation, LAD diagonal, left main, or circ, I always go to a 7 French sheath because I'm prepared to image both branches. And with the technique that we use for imaging for OCT, we always like to prepare beforehand using the MLD max algorithm. So here you see the baseline LAD OCT. And what's going to be different about Ultron 2.0, the first confusing thing, which you get used to pretty quickly, is proximal and distal is different. Distal is to your right and proximal is to your left. So that throws you off a little. But you have your angiographic co-registration on the left, and the co-registration here is a marked improvement before. You have your cross-sectional image on the top right, and then you have your 3D luminal image down there, which gives you the length of stent you're going to use, so you can get into normal tissue. It gives you the luminal area. It gives you EEL detection. So if it could detect EEL, you see those dotted lines on the 3-dimensional screen. That's an area where the computer can analyze EEL. So it gives you automated calculated EEL. So if you look on the 3-dimensional screen over here, you see 2.82 distally is my EEL. Approximately couldn't tell you, so you have to measure it, but you have a lumen area 254. It's 23 millimeters length. And I can actually measure, so I can pot very accurately, how many millimeters after a bifurcation I need to go to get to normal tissue. So instead of a 23, if I needed a 28 because I wasn't landing in normal tissue, I can optimize my landing zone of pot. So you're just not putting an 8 in, you're putting in length of a stent to get the best tissue. It's given me a wealth of information. So I have, you'll see it, I have morphology, I have length, I have size, I have lumen. So let's look at this baseline LAD morphology. And all this is artificial intelligence. So in my cross-sectional area, you see there's an orange line there that depicts calcium. And if you click on the screen to the right, you could blow it up and see the total angle of calcium and the thickness of calcium, which is tremendous information. And you can set this to any display threshold you want. If 180 degrees is what you want to see, then anything 180 degrees or more will light up on your screen as orange, and you'll see in co-registration, it'll line up on the actual vessel on your angiogram. So you know exactly the depth and length of calcium, which is critical in assessing if you need to do pre-treatment with some type of atherectomy device. And here I see I have mixed morphology. There is calcium. The arc maximum is 7.3 with a thickness of 0.73. Lets me determine what I'm going to do. Now, in terms of length, I can set my distal and proximal markers, and I'm all about landing zones. I want to land in a good landing zone on both sides, proximal and distal, so I know I'm not going to have a dissection. And the dotted lines on the bottom or on the cross section, you see those dashes represent where the computer is analyzing EEL. And if it analyzes ELL, I see distally I'm 2.82, and that'll tell me that I'm going to go with, let's say, a 275 stent. My length is 223 millimeters, and I have 8 millimeters where I can pot to get to a bigger size vessel. So that was length. Now I want to get diameter. And as I pointed out before, distally, I have EEL calculated by the computer, but approximately I had to measure it. And when I measure it, I can measure it at 3.87. So artificial intelligence helps me along with measurement of calcium and measurement of the size of the vessel, the diameter. So my baseline LED OCT information, it told me about calcium, it told me my length, and it told me my diameter. So once I do the LED, I now go to my diagonal. And in the diagonal, I see that I have pretty significant disease at the bifurcation, where you can see at the bottom of the screen, it says MLA. I have my MLA listed there. So I know my MLA, and eventually I'll know my MSA as well. And everything's depicted for you. So I know I need a 12 millimeter stent. My EEL distally is 2.34, and I'll calculate it approximately. So now we go to morphology. It's fibrocalcific. It has a 70-degree arc, 2.73 millimeters in thickness. My length is 12 millimeters. And I come up with my distal reference, 234. So now I have all the information I have in my baseline LED and diagonal, so I can go ahead and strategize how I'm going to do this procedure. And here is a summary of my diagonal information. And please keep this in mind, for both the LED and diagonal, this takes me less than a minute to do each one, less than a minute to get all this information. I have my MLA, I have my areas and my diameters. So first I do a non-compliant balloon in the diagonal, a non-compliant balloon in the LED. I then follow with a drug-eluting stent in the diagonal. I then use a non-compliant balloon in the LED to crush that stent. And I go, I don't use DK crush, but I think that any technique you use, and there are many different techniques we use, whether it's culotte crush or this mini crush or boom technique, as long as you document it with imaging, I think you're doing the right thing. So I then follow with kissing balloons in the LED and diagonal to open up my struts. And then I follow with a 275-23 in the LED. I pop with a 3.5 balloon in the LED, and all this was calculated beforehand, knowing I need it. I then recross, and I use non-compliant balloons in both vessels. I dilate and I kiss. And now I have my final OCT in the LED. And what I'm going to be looking for in the final OCT of the LED is, do I have distal dissection, proximal dissection? And because my landing zones are good, I should not have that. And what's beautiful about this technology is that it tells you if you have stent expansion or not. And if your stent is not expanded, and again, you could set this to 90%, 80%, it'll show up on your co-registration over here where it's white, it would show yellow. So you know exactly where you have to dilate afterwards if you're underexpanded, and it also shows you malapposition. So both on your co-registration and your three-dimensional, you can see where you are. So that's my final OCT, the LED, and now I look at my diagonal, and I'm going to see the bifurcation there, and I have no dissection. So I know I have expansion in both the LED and diagonal. I have apposition. I don't have dissection. And this is my final LED run. And you can see no dissection distally. My areas, my percent expansion, you can scroll, you see it all across the board where your expansion is, but here I'm 99, you can see at the bottom, it shows 99 expansion, MSA of 4.46, all the data's at your hands. And here's my bifurcation. Here's the LED, and there's the diagonal. And you see that two perfect circles, which I like. So my baseline LED, I have no dissection. My proximal and distal reference, I have 100% expansion of both sites. I have excellent apposition. The orange where it shows its malapposition is just a bifurcation, so it's not really malapposition. And this summarizes it right here. You see 100% expanded with MSA of 4.4A. That's my LED. And here you see the apposition, my bifurcation, and my expansion 100%. And the final LED assessment is no dissection, excellent apposition, excellent expansion. And this is the three-dimensional picture of it. Now I'm going to look at my diagonal and do the same thing. So I'm going to check to see that if I have dissection, do I have expansion, and apposition. And you could see in a matter of moments, you could see exactly where you stand with your diagonal bifurcation. I have excellent luminal area at the bifurcation point where the restenosis rate is the highest. And my MSA is 3.13. There is no medial dissection, as you can see in the cross-sectional. And I have excellent apposition. You see those two beautiful circles at the bifurcation. And I have 92% expansion. So, in summary, no dissection, apposition with excellent expansion. Now, the beauty of this also is this OCT software shows me what I started with and what I finished with. On the top, you could see that I start with an MLA of 2.12, and when I finish, I have an MLA of 4.57 with 100% expansion. I can play them side by side, and now I do the same for my diagonal. I had an MSA of 0.92 up to 3.12. Very elegant to compare these two. This is all new software technology. So in conclusion, there are many techniques you can use for bifurcation treatment. The only thing that's critical to me is imaging, whether you use IVUS or OCT, whatever you're comfortable with. I don't think you could do imaging successfully, or bifurcation successfully without imaging. And you can't just put a catheter down. You need to have a pre-treatment strategy. You need a stepwise approach using MLD max with co-registration to guarantee that you're going to get the best result. And if you look at that cross-section on the left, that's what I like to see when I have a bifurcation. Thank you.
Terrific, Rich. We have a couple of minutes maybe for a little bit of discussion or maybe questions. And while our panelists are gathering their thoughts, maybe I'll ask, how often, I mean, Rich, you're a big OCT user. And as you demonstrated very elegantly in that talk, you get a tremendous amount of information that allows you to plan your procedure. How often are you having to, post-dilate multiple times, or have you minimized that because you already sort of know exactly what the vessel dimensions are, what the amount of calcification, tell us a little bit about that. Have you reduced the resource use in your lab?
So what's great about, when people first tell me why they don't use OCT, and there are 50 different reasons why they don't use it, and there's only one reason why people don't use it is because they're lazy. But, one of the reasons is that it takes too much time, but I totally disagree. I take many less angiograms beforehand because I'm looking in three-dimensionally. So I'm using less angio, less fluoro, number one. Number two, as we pointed out, I know exactly the length of stent, the size of the balloon I need to pot in each vessel. So as I'm doing things, my staff is getting all the equipment. It's right there. And I'm doing everything beforehand. I'm not doing anything in between and going back and looking. So to answer your question, if I know I have greater than 270-degree calcium that has depth, I'm going to shockwave that, right? So I'm not going to be in a situation where I have to keep going back with balloons and just be satisfied with the result. I'm going to document fracture before I stent. So I know I'm going to have full expansion. So you're absolutely right. OCT lets me, with precision, optimize beforehand, so it takes much less time after.
Dr. Pinilla, let me ask you a question. I mean, you've been really heavily involved in education internationally around OCT. Some of the complaints I've heard, or maybe not complaints, but maybe apprehension around OCT, particularly for people who have used a lot of IVUS, is that they have trouble adjusting their mind's eye to the images at OCT that OCT shows. Can you talk a little bit about how you approach the training for OCT when you're giving lectures or when you're training fellows?
Yeah, it's interesting because people that have been using IVUS for a long time feel very confident doing it. So I think I agree with Richard in the point that if you're very confident with one technique and it works for you and you use it in your patients, then you should use that one. If you had any interest to train in another imaging technique is when OCT comes. So we see since OCT has been available, training in OCT with all of these artificial intelligence and tools of the OCT consoles, as Richard demonstrated in his talk, are pretty useful when you're doing PCI. So I find the new generations love this artificial intelligence, a software that tells you where the calcium, where the EL, where the measurements are. And I find extremely, it's actually easier to train people in OCT when in your post-PCI, in less than 1 minute, you're seeing your color code. You see white for a position, you go to both proximal and distal edges, and you look at this function number, and you're done. So people are, if you train them in OCT, they understand how efficient they could be. And I think the switch will come from that. However, training people in imaging, I will say not everybody has both modalities, imaging modalities in their CAD lab. So if they have either, be comfortable with what you have. If you have both, use them appropriately, right? Like sometimes we use eyeballs for osteal vein, for vein grafts, for big vessels. So I think being efficient with both is helpful. And if you have both, training both, I think that will be the message.
Great. Tanvir, any comments before we go on to the final lecture? Sorry, you're muted there, Tanvir.
Let's ask Professor Murasato what his thoughts are on the OCT's new software and what his thoughts are about how he approaches bifurcation.
Yeah.
I approached the bifurcation intervention using the OCT as a pre-PCI observation for the member cell and the side branch to identify the vessel size and morphology and calcification distribution. So that resulted in the optimal device selection and over treatment for the side branch. So we can select the optimal size for the and the optimal device for the bifurcation intervention. And after PCI and side branch wiring, we assess the side branch wiring recursion point and optimal port. After port and side branch wiring, and we assess the side branch wiring and assessing the port efficacy, especially as a bifurcation core, polygon expansion is very important for the optimal port. And then finally, we assess the stent expansion position in the final Kissenbaum inflation. So we at least the pullbacks 4 or 5 pullback for the bifurcation intervention. Therefore, we use to reduce the contrast medium, we use the dextran. And so that is the purpose of to use dextran instead of the contrast medium. As a result, the amount of the contrast medium is not different from the IVAS guidance.
Yeah.
Professor Murasato, do you think the new software that Richard showed will do you think your rewiring strategies might improve with the new software?
The new software, I hear about introduce the new software with the 3D contraction system. Now, present system does not develop, does not have the 3D system. However, we still have the 3D system. So in the bifurcation PCI, we still use the 3D OCT system. So maybe next year, they about developed the new system with AI system and 3D reconstruction system. So we can use the both of the system.
So for someone who's just coming out of fellowship, that is predominantly trained in IVUS or is mid-career and wants to make a pivot into imaging, what's the most practical way to get trained on these systems?
Natalia, maybe you can take that question.
Yeah, so I think education is the most important both barrier and the one that opens your confidence to use these technologies. Honestly, I feel any fellowship program should have experts in imaging modalities that could offer the fellows training in both technologies. Like a fellowship program should have faculty and professors that are very confident in both and open these both windows to the fellows. And I think all companies in general have like an amazing opportunities for training. Once you do like systematic training, I believe the easiest cases you pick to do imaging, the better in the beginning. So don't do training and go for a double stent bifurcation PCI because it will be very overwhelming. So I recommend once you have an idea how these consoles and the tools and the artificial intelligence, use it in easy cases for you to become comfortable with the softwares. And once you do that, you do 10, 15 cases, well, that is when you jump into a little bit more complex cases. But I believe the strengths in imaging come from good training from your fellowship program for sure. and using these opportunities of these webinars and all these opportunities for training.
Great. Looks like we've been joined by Dr. Zhang, who's going to present our third presentation, and it's going to be a case presentation of IVUS-guided left main bifurcation stenting. Dr. Zhang?
Okay, thank you very much for invited me. So this is a challenging case, complex PCI with a distal left main bifurcation lesions. We treated with DK crush with IVUS-guided. This is a 50-year-old gentleman presented with exertional chest pain and the shortness of breath for 1 month. Laboratory examination show elevated BMP, and also you can see ECG. There were Q waiver in anterior wall. Echocardiography show hypokinesis in anterior wall and with reduced LVEF only 32%. Clinical diagnosis is unstable angina, old anterior MI, and half ref. Next, please. So this is a baseline angiogram. Please clip the left panel. Yeah, you can see this is the RCA angiogram. There is a diffuse lesion from the proximal to the distal, and also with the severe calcification. Next. This is left coronary. You can see it's a typical distal left main bifurcation lesions involve distal left main extended to diffuse the severe calcified LAD lesion, and also you can see including the circumflex very diffused. Next. Next, yeah. This is AP cranial view at previous one, yeah. This
Go back one, Rebecca. Go back one.
Yeah.
Just play both. Chicken both.
Yeah. Thank you. So you can see from the AP cranial and IO cranial view, you can see also very diffused LAD with severe calcified lesions. Involved the second, actually, it's a large diagonal. Next, please. So according to the baseline angiogram, the syntax score is quite high, 61, and also syntax score also show the high mortality for PCI compared with cabbage. In terms of the distal left main bifurcation lesions, according to the definition criteria, it's a complex left main bifurcation. And in terms of LAD diagonal true, it's a simple bifurcation. So next. So of course, we will do the hard team discussion. Unfortunately, the patient and his family were reluctant to receive cabbage for this default treatment approach for this particular case. So finally, decision was to perform stage PCI for this case. So first stage, we will perform RCA with IBP. Then second stage PCI for left coronary, we will use ECMO with IBP with treated the complex left main and the simple LAD bifurcation lesions. In terms, actually, this case is a quite severe calcification involve either RCA and the left coronary, low ablation, and actually, if needed from the intracoronary imaging, IVL may be needed. Next. So this is the first PCI. So considering it's a low LVEF case, we use IBP support with a 7 French guiding cassette. Next. After two balloon predilation, we inserted IVUS. IVUS show actually there is KRC arc was only 118 degrees. So decision was to use next slides, cutting balloon to treat these RCA calcification lesions. So we use sequentially use 2.5 cutting, then followed by 2.75 and 3 NC balloon before standing to get optimal lesion prepare. Next slides. So after good lesion prepare, with the support of the extension Godzilla cassette, we insert 3 DES, fully cover from the distal RCA to the ostimal RCA. Next. So this is the final result. You can see from the angio, it's optimal. Of course, we will check the IVUS. So after IVUS check, the minimal stain area for the RCA standing was 5.2 millimeter square, larger than 5 millimeter square. It's according to the ultimate criteria, it's optimal result. So next. So 3 days later, the second stage PCI for the left corner lesions, still considering it's a low LVEF for a high-risk patient and also complex PCI. It's a typical CHEP case. So we decided to use ECMO Pulse IVP to support. So we, from the right radial approach, use a 7-branch EBU 3.5 guiding cassette to engage the left main. So from the baseline angio, you can see it's a typical distal complex left main bifurcation. In terms of the second diagonal, it's a very short lesions. So it's a simple LAD diagonal bifurcation. Next. So according to the definition criteria proposed by Professor Xiaoliang Chen, it's a typical left main complex bifurcation. Decision was made to treat it with DK crush. For the LAD diagonal 2 bifurcation, it's a simple. So decision was made to perform provisional standing with a geared wire or geared balloon, protect the second diagonal. Of course, for all these complex lesions, so intracorneal imaging guidance was mandatory. So we decided to still use IVUS guidance. In terms of the severe calcification, low ablation or further IVR may be needed according to the intracorneal imaging guidance. Next. Next. So with the IBP and the ECMO support, we use 203 small balloon predilation, the distal left main, LAD, and the circumflex. Then we insert the IVUS cassette to get the baseline intracorneal imaging modality. Next. So this is a baseline IVUS imaging of the LAD. You can see the distal reference vessel diameter was 2.25, and the minimal lumen LAD was only 1.45. And also you can see in the proximal LAD there is 306-degree superficial calcification. In terms of distal left main, very tight lesions, MA only 3.94. And also you can see the EM is quite large, diameter more than 5 millimeters. Next. We also pull back from the circumflex, go to circumflex information. Distal reference, you can see is 2.8, and also the optimal circumflex was less, only 216 millimeters square. Actually, there is in the middle OM, there is negative remodeling. The vessel size only 2.45. We should be cautious when selecting the stent size. The total circumflex length is 32 millimeters. Next. So after the intracorneal imaging, according to the IVUS imaging, there is a very superficial and the 300 arc degree calcification. We perform low ablation with a 1.5 burr, 26 by 3 rounds. Fully do the low ablation, low asterectomy for the proximal LAD to the middle LAD. Next. Then following low ablation, we check the IVUS again. Actually, you can see the middle LAD, there is a reverberation phenomenon after low ablation, which means we have cracked the superficial calcification. But still, in the proximal LAD, you can see still there is a nearly 300 arc degree the calcification. Maybe for this site, may need a further region prepare with IVR with a sugar balloon. Next. So for the middle LAD, after low ablation, we followed with a 2.5 NC balloon to further predilation before standing. Next. Then with geared wire, and the jet balloon protect the second diagonal with the provisional standing. The first stand is 2.25, just put in the distal ending. The second stand 2.75 by 30 millimeter, just cross over the optimal of second diagonal with 1.5 jet balloon to protect the diagonal. Next. So after we treated the middle and the distal LED, we check the iris again. You can see the distal landing zone is good, plug burden less than 50%, and also still show there is a 270 arc calcification at the proximal LED. So decision was made to perform the IVR treatment with the Schuylkill balloon. Next. So according to the IVR imaging, so 3.5 Schuylkill balloon was used to treat the proximal LED calcific lesions. So after IVR treatment, we check the iris again and show there is a crack after the IVR treatment. So which means it's a good lesion prepare. Then we will switch to treat the distal left main bifurcation lesions. Next slide. So for the distal left main complex bifurcation, so decay crush was mandatory. So lesion prepare with 2.25 NC scoring balloon for the treatment of the optimal circumflex. Next. Then followed by 2.538 DES with a minimal protruding 2 millimeter into left main. After side branch standing, 2.75 ounce balloon was used to post-dilation the optimal circumflex, make a stem fully expansion. Next. Okay, then next step is first crush. We first use a 3.5 NC balloon from the distal left main to proximal ending. Then further crush with a 4.0 balloon, because according to the iris imaging, left main is quite large. The EM is a 5.0. We use a 4.0 balloon to crush again, get a fully crush. Next. So then we first rewiring to the circumflex from the proximal cell, then followed with the first casing 3.5 by with a 2.75 NC balloon. First casing. Next. Then main method standing is followed 3.5 by 26 DES fully cover from the ostium left main to the proximal LED. Follow the left main method standing, we will still use a 4.0 balloon to do the report, make the stem fully expansion. Next. Then second rewiring and the second kissing still with the 3.5 and the 2.75 NC balloon, and finish with the 4.0 balloon report. Next. So this is the final angiogram. You can see from the angiogram, it's a quite good result. Next. Then we will still check the iris. You can see we got the LED wrong and the circumflex wrong. So distal LED landing zone plug burden less than 30%. The minimum stain area of the middle LED was larger than 5.0, proximal larger than 8. And also distal left main, we got more than 10 millimeter square. And also the proximal circumflex is larger than 6 millimeter square. Next. So, ladies and gentlemen, let's take conclusion. For complex lesions, IVR guidance is mandatory to reduce the risk of cardiac death and MACE. The definition criteria can distinguish complex from simple bifurcation lesions. Definition 2 chart confirmed that the two-standing technique, especially decay crush, was associated with a superior result compared with the provisional standing technique. for the treatment of complex bifurcation lesions at 3 years follow-up. In true bifurcation left-man lesions, DK crush could be performed over prominent T standing. For this kind of cheap case, especially with a low LVEF ECMO with a IBP supporter will maintain the hemodynamic stable during the PCI. Thanks for your attention.
Wow, that is a master class in complex PCI. Amazing. I've never seen a syntax score of 61. You really beautiful result and very meticulous technique. And the fact that even after all of that work, you took time to image the final result to make sure that it was a durable result. Congratulations on that fantastic case. I'll ask Dr. Panilla to maybe make a comment or two.
Yeah, I wanna. These cases were amazing. With this, the complexity was quite high. With imaging, we see more than what we want to see when we are doing this bifurcation. So we see more complex plaque morphology. We probably see our wire going through the struct that we were not aiming to get, like pods that are not as optimal as we were expecting. So and interesting to hear from the speakers. How often or how systematic they are with the wire recrossing. I was impressed by Dr. Murasato's presentation. We say first attempt, second attempt, third attempt. So how often do we keep re-imaging to make sure we are across the stent strat we are aiming to do depending on the bifurcation technique we decided?
Thank you very much. It's quite a very important point for the two-stent technique, the wire reaccess. In terms of DK crush, first and second wire should from the proximal cell. So of course, OCT there is a fly model we can see the online. But for the IVUS imaging, we can also use IVUS guided the Y access. Actually, this is a live demonstration. This case is from I think it's 3 months ago. So Professor Chen and us performed this case. It's from the 320 medical stream live case. Actually, during the live case, we after rewinding to the circumflex, we still inserted IVUS auto pullback from the LAD to distal left main. So there is some tips. So we can define the optimal point, LAD point, and the distal left main point. Then there is maybe we can calculate the total slides we have. Then if we check the wiring from the circumflex to the LAD is just at the proximal part of the IVUS image slides, which defined as the proximal access. Otherwise, there will be decided distal access. So through this method, we can precisely define the proximal access with the DK crush, not only from the angio, but also from the IVUS image.
Perfect. Thank you for sharing that. And Richard, I have a question for you. Now with the OCT and the question whether we are going to use more contrast or not, how often I find when we use no pure contrast for OCT, sometimes we don't have perfect images, but now we are using other contrast media, as Dr. Murasato shared with us. So how often do you use those media no pure contrast? And you use a pre-PCI, post-PCI. I find quite challenging getting a post-PCI, no pure contrast OCT image. Richard, you're muted.
So a couple of comments. Dr. Murasato, one exciting thing I want to tell you, I didn't show it, but in the Ultron 2.0, we have three-dimensional. We have amazing three-dimensional, so you don't have to use the O system at all. You can spin it, you could do everything with it. You could zoom it, you have carina view, you have osteal view. Next time I'll show it to you. I didn't bring it up on this case, but you do have three-dimensional imaging on the Ultron 2.0. And to answer your question, Natalia, instead of dextrose, what I use routinely is saline. And in the RCA and circumflex, I get pristine runs with saline. And if I don't, I can redo it because it's saline. And the LAD, I just do a mid and proximal run and I get saline. So we do a lot of no contrast angioplasty, or super low contrast angioplasty at St. Francis, where we use saline or high definition IVUS. But I use OCT with saline for all my renal cases, and I can do as many runs as I want. One quick question for Dr. Morisato. I was fascinated by your wiring techniques, as Natalia was. My question is, do you leave one wire in if you've imaged and you're in the wrong cell just to help direct you? And do you just keep putting wires in until you get to the right spot? Because I'm not as expert as you in that area, and I'm going to try doing it. But as a technique, you leave the wire down and then keep going till you get the next one?
Yes, if we mistake the optimal wiring, we keep the suboptimal wire in the side branch, and we use double main catheter. So double main catheter inserted to the suboptimal wire, and the next wire aiming to the more distal side. So if we achieve optimal wiring, double main catheter lock like this. Suboptimal wiring and optimal wiring, double main catheter lock stop the cardinal area. So we can achieve the optimal wiring. In such technique, we achieve the optimal wiring.
So you usually use a double lumen catheter when you're doing a side branch routinely?
Yes. No, routinely. However, firstly, we use the pullback wire advancing. However, we fail the optimal wiring, identified as 3D OCT. We use the double main catheter.
Okay, great.
Really interesting. I think one of the things that I kept coming back to in the presentations by Professor Morisato, by Dr. Schlafmitz, by Dr. Zhang, is the fact that the imaging was done initially to help plan the procedure. There's a plan that is then executed based on the imaging, and then the imaging is done afterward. And I think one of the issues around bifurcation stenting is to make sure that you have that plan and you continue to work that plan. You can't be in a hurry. You have to be very meticulous, because I think, as noted at the beginning of this webinar, bifurcations are still, and CTOs are really the final frontier for PCI. And in order for us to be able to get outcomes as good as bypass surgery, it's very, very important to make sure that you're doing things in a methodical way. So Richard, maybe I'll ask you a little bit. I mean, you're someone who has adopted imaging, sort of wholesale in your practice, which I think, just talking with you personally, has been a relatively recent phenomenon over the last 5 to 7 years or so. Can you talk a little bit about, how you came to that decision and why you've continued to use imaging in your complex cases?
So I'm getting older, Sunil. It's around 10 years now. I've been in practice 38 years. And for the first 27 years, I thought I was a really good angiographer. I didn't realize how mediocre I was until I came upon imaging. And it wasn't easy. It took me 2 years to really transform it to 95%. And then there's a moment when you look at it and you say to yourself, oh, that's a 275 LED, and you measure it, it's a 4.0, and you hold your breath when you put the 4.0 in there, and it changes your life forever professionally. And it really is about a comfort zone. We're comfortable with angiography, so we think we know what we're looking at. But once you start imaging, you realize how impotent angiography is. And it's sort of, I felt like I was on a mission now. And my whole professional career is, I'm so excited about how it changed my life. That's what I want to do for everybody else. So it's when you see how imaging, there is no such thing as a type A lesion until you image, in my opinion. Because I think Professor brought up something like, unrecognizable things. So many times on a 3-dimensional, you're focusing on the midcirc, and then there's an osteocirc lesion that you would have missed. So many times when you say, oh, a stress thallium test, it was a false alarm, or a CT angio was a false alarm, the false alarm is not imaging.
Yeah, that's fantastic. Well, I want to thank everyone for attending this fantastic SCAI webinar. I'm going to turn it over to Dr. Rob for final thoughts and maybe a summary.
So thank you very much for participating. The important message is complex PCI cannot be done without imaging. And certainly bifurcation PCI is so important that you use imaging, otherwise patient will have fatal consequences if you don't do it right, particularly if you do a 2-stent technique like DK crush. So I think both imaging modalities are great. And certainly OCT, as demonstrated, and also IVUS, has to be maximized. And you need to get to be very good at it, to be able to do this procedure. But without imaging, I think particularly bifurcation stenting is incomplete. So I want to thank all our guests, particularly our guests from overseas, in a different time zone right now. And thank you for presenting your excellent cases, and I hope all our guests enjoyed it. John, do you have any final comments from the chat group, or
I think the panel actually addressed everything from the chat in the last discussion. So thanks, everyone. Really appreciate it.
Thank you very much, and we're going to end in time. And good night.
Thank you.